Hi, I'm Paul Epstein, and I'm going to talk to you now about some salient points about therapy of depression for the day one of the ILO on treatment of mood disorders. Okay, the objectives for this presentation are going to be for you to get some understanding of drugs that are used to treat depression, how they act, what some of the advantages of SSRIs, which are serotonin selective reuptake inhibitors, are, and of some of the new atypical antidepressants over the older tricyclic antidepressants or TCAs and the older monoamine oxidase inhibitors or MAOIs, and also to appreciate some of the adverse effects associated with use of these different antidepressants. So the DSM-5 criteria for what constitutes a diagnosis of major depressive disorder is that someone should exhibit 5 of these 9 affects for at least a 2-week period. And one of the symptoms must be either diminished interest or depressed mood. And as you can see on the left with the highlighted first letter in yellow, there's a kind of a mnemonic you can use to try to remember the 9 symptoms or affects that people with major depressive disorder will exhibit. So another important question that often comes up is how long to treat with these antidepressants. One thing to know is that all of the antidepressants, with the exception of esketamine, which works fairly rapidly, is that they all take minimally several weeks to see an effect, and often it can be even as long as 6 to 8 weeks to begin to see a full effect. But the current recommendations are that with the first episode of depression, one should treat for 9 to 12 months from the point at which the patient has responded to the antidepressant. For a second episode, treat longer. And for a third episode, it's believed that a lifetime permanent maintenance therapy is called for to prevent recurrences. So, what classes of antidepressants are available or are out there? And this this slide shows that there was in the 1950s 2 classes of antidepressants became available or were developed, both serendipitously. And the first one grouping is called tricyclic antidepressants. The other is called monoamine oxidase inhibitors. And it wasn't until the late 1980s that the first serotonin selective reuptake inhibitor, or SSRI, was approved, and that was fluoxetine or Prozac. And there is also another group called the SNRIs, which is the serotonin norepinephrine reuptake inhibitors. And then there are also a variety of heterocyclic atypical antidepressants that don't fit any of these categories. So as far as the tricyclic antidepressants are concerned, there are many out there. You can read in that brief synopsis that I wrote and posted as a separate file about this. But there are many. They're effective. Actually, all the antidepressants that are in use are pretty much comparable in efficacy. Where they differ is largely in the types and degrees of the side effects that they produce. So there's many tricyclic antidepressants, And they can be either a tertiary amine, as shown on the left here, or a secondary amine, as shown on the right. And the difference is that both of these are active drugs. Neither is a prodrug, but the tertiary amines are metabolized by the cytochrome P450s by N-demethylation to the active secondary amine. So typically, a tertiary amine will have a wider range of side effects than a secondary amine. That can be seen in a table I put in that synopsis on antidepressants that's in that file. So going on to the next slide, the thing about the tricyclic antidepressants is they interact with a wide range of targets. They inhibit many different receptor systems, as well as the amine uptake pumps for various neurotransmitters. So they produce a whole wide range of effects. It's generally believed, that the therapeutic effect of the antidepressants, in this case the tricyclics, derives from their ability to block the reuptake pumps of norepinephrine and serotonin, indicated as Ne and 5-HT here. But as I said, and as you can see here, even at very low concentrations, they block a whole range of receptors, like the alpha receptors, histamine H1 receptors, muscarinic acetylcholine receptors, and many of the serotonin receptors. In addition, at higher concentrations, they have a membrane action or quinidine-like effect on the heart, which produces cardiotoxicity and is lethal. So they're quite lethal at higher doses. So as a result of inhibiting all these other receptors, they produce what's called autonomic side effects. So what are those? So we can see on the next slide that, if you press advance, you'll see that there's blockage of alpha adrenergic receptors. Does what? What happens if you block an alpha adrenergic receptor? Well, that would result in orthostatic hypotension and erectile dysfunction. And if you block histamine H1 receptors, you get a result of sedation, appreciable sedation, and weight gain. And blockage of muscarinic acetylcholine receptors results in what's called atropine-like effects, which are classically blurred vision, dry mouth, constipation, urinary retention, and mental confusion. And finally, as I mentioned, you can get the cardiotoxicity from conduction block and arrhythmias, and this is usually lethal. So these were the drugs, one class of drugs available in the 1950s, and they're still approved today and in use. Another from back then was the monoamine oxidase inhibitors, and those were discovered because an anti-tuberculous drug called iproniazid was found to produce mood elevation in patients with tuberculosis. And it was then subsequently found that that drug inhibited monoamine oxidases. So the iproniazid is no longer in use because it was found to produce liver toxicity. But there are 4 other monoamine oxidase inhibitors currently in use. And again, they're very effective drugs, but because of some of the difficult side effects, they're not used very much at all right now. But the most troubling aspect of the use is the requirement for very strict dietary compliance, which I'll talk about shortly. So there are actually 2 types of monoamine oxidase, monoamine oxidase A and B, and these drugs, 3 out of the 4 of them are completely nonspecific and will block both types, non-selective for one or the other. Okay, the other thing is that the monoamine oxidase inhibitors also have a propensity for drug-drug interactions. As a result, they're contraindicated with using with SSRIs because otherwise you would tend to build up the levels of serotonin to be too high. Okay, so the four monoamine oxidase inhibitors that are approved for use are phenelzine, tranylcypromine, isocarboxazid, and selegiline, which is used as a transdermal patch. As I mentioned, these first three are non-selective. Selegiline at lower doses is somewhat selective for monoamine oxidase B, but as you get a little higher in dose, it also is non-selective. And the other thing about the monoamine oxidase inhibitors is that the two of these three above are irreversible inhibitors that react covalently with the active site of monoamine oxidase, and tranylcypromine, although not irreversible, is very long acting. As a result, if you give therapy with monoamine oxidase inhibitors and want to switch to a different antidepressant, you need to have about a 5-week washout period before applying a different antidepressant. All right. On the next slide, fluoxetine was released, which was free of many of those autonomic side effects that one saw with the tricyclic antidepressants because it very selectively inhibits the reuptake of serotonin. And a book was published shortly after by Kramer, a psychiatrist at Brown, called Listening to Prozac, in which he extolled the virtues of this SSRI in terms of its ability to dramatically improve patients' mood. And it became very popular. And so today, as shown on the next slide, we have a variety of SSRIs that are approved now to choose from. The two most recent at the bottom, the vilazodone and vortioxetine, do a little more than just blocking the reuptake of serotonin. In addition, they have some ability to interact with the serotonin receptors themselves. Depending on which type of receptor, there are about 14 different serotonin receptors with different subtypes, and these two agents, depending on the particular serotonin subtype, they can be agonists or partial agonists of some or antagonists of others. So they're sometimes referred to, these drugs, as multimodal serotonergic agents to distinguish them a little bit from the pure SSRIs. Now, another class of drugs that has been come out as well more recently are what we call, as shown on the next slide, the SNRIs, which stands for serotonin norepinephrine reuptake inhibitors. And these drugs, unlike the SSRIs, they block not only the reuptake of serotonin, but also the reuptake of norepinephrine as well. So they have a little wider spectrum of what they might be able to do. Amongst these four, it's actually only the last one at the bottom, the levomilnacipran, is the only one that shows more selectivity for blocking reuptake of norepinephrine than that of serotonin. I think it's about twofold more selective. The other three, at low doses, are really more just almost like an SSRI because they're much more selective for serotonin, and they don't begin to inhibit the norepinephrine uptake until you get to higher doses. So how do the SSRIs stack up with the earlier tricyclics antidepressants, for example? Well, as we alluded to, they're much safer. They are not lethal on overdose. They show no anticholinergic or other no autonomic effects. They have very little sedation and no cardiac toxicity. But as you might imagine, they're not really free of their own side effects, because by flooding the system with serotonin with an SSRI, that serotonin is going to interact with all types of serotonin receptors. And you might get some wanted effects, some therapeutic wanted effects, and some unwanted effects by overstimulating another pathway. And on the next slide is a somewhat simplification, but tried we try to figure more or less which serotonin receptor might be mediating which actions. And it's thought that the 5-HT1 might mediate the actions of these agents as antidepressant and anxiolytic effects. And the 5-HT2 is probably contributing to agitation, nervousness, insomnia, and sexual dysfunction, which are unwanted side effects of the SSRIs. And the 5-HT3 likewise would be promoting other unwanted side effects like nausea and vomiting, and to some degree headache. So on the next slide again shows some of the side effects that one can experience with SSRI. The first three on this list are fairly common, but particularly sexual dysfunction occurs, I would say, in the majority of patients that take SSRIs. Also, GI disturbances is fairly common, although that tends to go away with time as you develop tolerance to it. And also, many of the SSRIs, I think maybe with the exception of fluoxetine, they all tend to promote weight gain on long-term use. Now, metabolic syndrome and liver toxicity has been observed in some patients. It's not that frequent, but it can occur. And finally, they all produce an increased risk of hemorrhage during surgery, because increased serotonin blocks platelet aggregation. So there is a risk for that to be aware of. So when you give a patient an SSRI, which is the first line agents today, so what might happen is shown on the next slide. An adverse reaction that can occur pretty much right away is the development of some of these symptoms. Particularly, patient might experience akathisia, which is kind of best described as a inner restlessness where you can't sit still. You just can't get comfortable. And you might have activation where you have trembling, agitation, and then it can go on along this spectrum if if it continues in this way, to produce muscle contractions and clonus, and hyperthermia, and eventually death from what's called serotonin syndrome. So if you have to monitor the patient carefully. If you start them on too high a dose initially, this can result, and you have to lower the dose immediately or take them off the drug to prevent any further adverse or even potential lethal effects. Similarly, to discontinue an SSRI, if somebody has been on it for quite some time, who might want to say try getting off, it's not a good thing at all to stop it immediately. What happens then, as shown on the next slide, is that you would get something called the serotonin discontinuation syndrome, which, although not lethal like serotonin syndrome, which can occur when you first administer an SSRI, it's very disturbing and uncomfortable. You get flu-like symptoms, vertigo, sensory disturbances, anxiety, hyperarousal. So the only way to stop that is to immediately start taking the drug again. And so that the take home lesson here is to taper very slowly when wanting to get off of an SSRI. And the discontinuation syndrome would appear more frequently in the antidepressants that have shorter half-lives, like venlafaxine and Paxil. Like fluoxetine, which has a very long half-life, will stay in your system longer, so you won't notice the discontinuation syndrome quite as much. Another thing about the SSRIs is shown on the next slide, is they have a capacity to inhibit different forms of the liver metabolizing enzymes, like the cytochrome P450 drugs. I mean, enzymes that metabolize drugs. In particular, the CYP2D6 form of the cytochrome P450 is a form responsible for metabolizing very many common drugs, such as the antidepressants themselves, the antipsychotics, antiarrhythmics, beta blockers, opiates, and many others. And so the one SSRI that seems to have less ability to inhibit that form of P450 as well as others is the escitalopram, which is Lexapro. And that's a consideration to think of when you have people who might be on a whole wide variety of other agents and you want to try to avoid drug-drug interactions. So since fluoxetine or Prozac was developed came out in 1980, as noted here, a lot of other additional antidepressants have been marketed since the fluoxetine was first marketed in 1988, and these are all given here. The most recent two were both approved in 2019, and those are at the bottom. It's brexanolone, specifically for postpartum depression, and esketamine, specifically for treatment-resistant depression. And those two differ from all the others in as much as they work almost right away, whereas all the other antidepressants take weeks, several weeks at least, to begin to show an effect. I'm not going to go over the specifics of every one of these since I'm trying to keep the video a little bit shorter, but they're listed in the extended PowerPoint that I will be posting as well, so you can look that up. But there are two agents here that I would want to make a few points about in the following slides, specifically bupropion and mirtazapine, and I'll go on to those now. What do we know about bupropion? Bupropion is unique amongst the antidepressants in that it has no effects at all on serotonin. It's, to my knowledge, the only one. What bupropion primarily does is to block the reuptake of dopamine. However, there is an active metabolite of bupropion that also weakly blocks the reuptake of norepinephrine. So exactly how it's working is not entirely clear, but for some patients it definitely works. And then one of the nice things about bupropion is it doesn't have all those autonomic side effects that the tricyclics do, or the dietary restrictions that monoamine oxidase inhibitors have. It doesn't also produce weight gain. And particularly, it has no sexual dysfunction associated with it, and moreover, it seems capable of correcting or overcoming the sexual dysfunction effects produced by the classic SSRIs when used in combination, by virtue of its ability to enhance the dopamine levels. So very frequently, not infrequently anyway, bupropion is sometimes often used in conjunction with an SSRI in cases of patients that are exhibiting sexual dysfunction side effects. So the other agent I want to just point something out about is shown on this next slide is mirtazapine. And mirtazapine, I just want to call to your attention, unlike the other agents we looked at, does not inhibit any of the neurotransmitter reuptake pumps. Rather, it's an antagonist of the alpha 2 presynaptic receptors. And by antagonizing that receptor, it disinhibits the norepinephrine and 5-HT2 serotonin, so that you get more release of norepinephrine and 5-HT from the nerve terminal. However, in addition to enhancing release of these neurotransmitters, mirtazapine also interacts postsynaptically with the 5-HT2 and 5-HT3 postsynaptic receptors, and thereby blocks some of the adverse effects that one would see due to the increased serotonin. It also has little or no sexual dysfunction or GI disturbance. However, mirtazapine does very greatly interact with the histamine H1 receptor as an antagonist. As an agonist rather, and produces appreciable sedation and a very appreciable weight gain due to increased appetite. So it's typically sometimes not often used as a first-line agent because of the appreciable sedation and weight gain that results from the use of mirtazapine. But other than that, it is an effective antidepressant. Also, in some patients, it causes a reduction in white blood cells, which has to be monitored. So, finally, in this last slide, we summarize what we've learned here about treating depression. First of all, depression is treatable. At least from the pharmacological standpoint, about 2/3 of patients can be treated that way. And as we'll learn in the cases and throughout this ILO, there are non-pharmacological treatments that can be used. In particular, ECT or electroconvulsive shock therapy is one effective method for treating drug-resistant or depression, and apparently esketamine may also fulfill that role. So the tricyclic antidepressants have appreciable autonomic side effects, and they're lethal at high doses. The monoamine oxidase inhibitors have these difficult dietary restrictions, and as a result, the SSRIs are the first-line agents. Also, as I mentioned, we have esketamine, which, different from, in contrast to all the other antidepressants, acts immediately. And so that we may see more use of this going forward. The thing to remember is that major depressive disorder is a very, very serious illness that can and does lead to death by suicide in about 20% of the people that are going through this. So it has to be taken very seriously, and everything possible should be used aggressively to treat depression. And this would include not only drug therapy, but counseling. In particular, one useful mode of counseling is cognitive behavior therapy, which Dr. Litt will go over in day 5 of this ILO. And also exercise would be a good adjunct along with drug therapies. Okay, thank you.